Everyone, today I'm going to talk about the renal disorders, a continuation class of the nephrotic syndrome. Yesterday we were discussing about the nephrotic syndrome, which were directly causing the renal pathology, but today we'll be discussing about the systemic diseases which cause the renal pathology or the nephrotic syndrome as such. So I'll be discussing on these headings. That is a recap of what I have taught yesterday, and then what is a nephrotic syndrome at a glance of all the nephritic and nephrotic syndrome, and IgA nephropathy in detail, hereditary nephritis, including Alport's benign familial hematuria, which includes the thin basement membrane lesion, chronic glomerulonephritis, glomerular lesions associated with systemic diseases, that is lupus, henoch-squamous purpura, diabetic nephropathy, diabetic nephropathy, and also amyloid and essential cryoglobulinemia, which will cause nephrotic syndrome. Okay. So what is nephrotic syndrome? I told you the nephrotic syndrome includes a cluster of diseases wherein the protein is excreted in the urine more than 3.5 grams per 24 hours. And then there is hypoalbuminemia, lipiduria, hyperlipidemia, and severe edema as such. So this nephrotic syndrome can be caused by various diseases, either primary glomerulopathies or secondary glomerulopathies caused by various systemic diseases. In the yesterday's class, we have seen that the primary glomerulopathies are the membranoproliferative disease type 1, type 2, the membranous nephropathy, FSGS, and minimal change disease, which we have discussed yesterday in detail. So, coming to the nephrotic syndrome, the pathogenesis, here we see that there is a glomerular damage that is happening. Usually in the nephrotic syndrome, the cytokines play a major role in the nephrotic syndrome pathology, and then the insulation of the plasma proteins into the urine. So what is happening when there is a glomerular damage? There will be increased permeability of the glomerular capillaries to protein. So thereby there is proteinuria. Usually initially the proteinuria is less than 3.5 grams per 24 hours, but then when the damage is accentuated by various other factors, then proteinuria may increase more than 3.5 grams per 24 hours. So what we will see because of this, because the protein is excreted in the urine, there will be hypoproteinemia, that is usually in the form of hyperalbuminemia. Okay. Initially, there is only albumin loss, but there can be globulin loss if the glomerular filtration rate and the glomerular filtration is damaged because of these factors. So when there is hypoproteinemia, you know that the plasma proteins are essential to maintain the plasma oncotic pressure. So whenever there is decrease in the plasma oncotic pressure, the fluid escapes into the tissues and then there will be edema. And here, whenever there is a plasma oncotic pressure, you know that there is no proper plasma volume. So because of that, there is decreased GFR. And in response to the decreased GFR, the aldosterone is getting secreted. You know, the function of the aldosterone is salted water retention. So thereby, it causes the fluid retention, and then it will cause edema. Usually, there is periorbital edema or swollen ankles, which you see initially, but if the proteinuria is more and then there is more hypoproteinemia, then it will cause severe edema owing to ascites and generalized edema. So this hypoproteinemia will be compensated by a normal body mechanism wherein there is more production of proteins by the liver. So the liver tries to compensate for the protein loss which is in the urine. So because of that, the lipoproteins are also a part of the protein structure which will get deposited more and more. So because of that, these lipoproteins will get increased and there will be hyperlipidemia. So this is the pathogenesis which is causing the proteinuria and the severe edema and the hyperlipidemia in nephrotic syndrome. So yesterday I told you that the primary glomerulopathies which are causing the nephrotic syndrome are usually the membranous nephropathy, minimal change disease, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis 1 and 2, right? So when we are discussing about these things, we have to discuss them under certain headings. Okay, first, age. The membranous nephropathy is usually present in adults ranging from 40 to 70 years. The minimal change is usually seen in children's. There is an adult variant of the minimal change disease which is rare. The focal segmental glomerulosclerosis, the age group involved can be both children and adults. MPGN 1 and 2 are usually associated or seen in the age group of children, young adults and adolescents. Okay. After that, coming to the other one, that is what are the features what we'll see. We know that there should be an immune reaction to form an injury to the glomerulus. Okay. So thereby causing the renal pathology. So what is happening here in membranous nephropathy is that there is an antigen called as phospholipase A2 receptor. This is a fixed antigen, and to this fixed antigen, there is an antibody coming and joining. So what happens? There will be an antigen-antibody reaction. And because of this, there is an immune complex formation, and this immune complex formation has to be degraded. So what is trying to degrade these immune complexes? The glomerular cells which are normal, they will try to degrade this by producing oxidases and proteases. Okay, these enzymes will then cause a damage to these immune complexes which are attached to the epithelial cells of the glomerular structure, and then what happens? There will be capillary leak. So there is a damage, there is an injury to the glomerulus because of the destruction of the immune complex, then there is the capillary leak happening. So thereby there will be the protein leak into the urine. And there is paucity of inflammatory factors in membranous nephropathy. Okay, so this is the pathological features which contribute to the membranous nephropathy. Coming to the minimal change disease, usually we know that the minimal change disease is having an immunological basis by there is an associated atopy, there can be a hereditary HLA equation there, and then there can be some respiratory infection which is leading to this disease. Okay. Usually the minimal change disease, the pathogenesis is unclear, but it is thought to be of loss of glomerular polyanions. Okay, so what happens because of that? There is podocytopathy, or the visceral epithelial cells will get effaced, and then there is protein leak because of the damage to the visceral epithelium. That is a pathogenesis which is leading the minimal change disease. You know, by definition, the minimal change disease is like there is no deposits which are formed, no immune complexes, but there is just a minimal change regarding to the visceral epithelium. Now coming to the focal segmental glomerular sclerosis, I told you focal means a fraction of glomeruli in the renal parenchyma are involved. Segmental means in each glomerulus, if we take a part of each glomerulus is involved. So the focal segmental glomerular sclerosis is usually can be a result of a circulating immune complex, or there can be some mutations in the genes which is trying to maintain the integrity of the visceral epithelium, as you know. So the visceral epithelium, I told you the structure, there are two visceral epithelial cells. Integrity is maintained by the nephrin molecule, the podosin, the actinin, the alpha-actinin TRPC6, right? So this nephrin molecule is an extracellular molecule encoded by the gene NPHS1, and whenever there is a mutation in this gene, it will cause a congenital nephrotic syndrome. Okay, the podosin, if there is a mutation in podosin, it will cause steroid-resistant nephrotic syndrome. If there is a mutation in alpha-actinin, it will cause autosomal dominant type of nephrotic syndrome. Okay, TRPC6 is essential channel which is trying to control the calcium flux. So any mutation in that will cause FSGS. So there is something called as apolipoprotein 1 which is also implicated in the pathogenesis of focal segmental glomerular sclerosis. I told you any lesion, any glomerular pathology initially will start by some inciting agent which will progress by two things. If you remember, I told you in the class before class, that is the FSGS and the tubulointerstitial disease, right? Remember these two. Then coming to the other one, MPGN1, that is membranoproliferative glomerulopathy. Here we see that the pathology is basically because of activation of the classical and alternate pathway. Usually We do not know what is the antigen which is causing the membranoproliferative glomerulopathy. Then here in MPGN2, there is again the main dense deposit disease MPGN2 is called as. This is because of activation of alternate complement pathway, and this alternate complement pathway mediated, if you remember in the inflammation chapter, we know that any inflammation because of the lipopolysaccharide of the bacteria or any toxin will try to cleave the C3, that is a C3, and formation will be leading to the C3b, right? So this C3b and C3, this thing, what happens is usually labile factor, and then it doesn't have a stable activity. But then if there is a C3 nephritic factor as seen in the disease of membranoproliferative type 2, then what will happen is that this gets stabilized and then this C3 gets activated and is seen deposited on the renal parenchyma. So what we are seeing here is the activation of C3. It is maintained by the C3 nephrotic factor, and then thereby as C3 is getting deposited, we do not find any kind of C3 in the plasma. So there is decreased plasma C3 levels and factor B or protein levels, but there is normal C1 and C4 complements. So the hypocomplementemia related to the dense deposit disease is usually pertaining to the C3, right? So after knowing about the pathogenesis, see, if you know the immune mechanism, what I told you about the glomerular injury, that is antibody mediated either to the fixed and planted antigen or by cell mediated about the sensitized T cells or about the alternate complement pathway. So you should fit all these diseases into either one of the mechanism, okay? So now, what are the microscopic features? The microscopic features are usually described in 3 ways, that is light microscopy, electron microscopy, and immunofluorescence. Under the light microscopy, what we see is a thickened basement membrane in membranous type. As you know, in minimal change, it is disease of only the visceral epithelial cells, effacement of food process seen only in the electron microscopy, and nothing will be visible in the light microscopy. In FSGS, we see sclerosis, that is extracellular collagen or matrix deposition, hyalinosis, that is exudation of the plasma proteins which appear as a hyaline material. Right? There can be obliteration of capillaries as such. If you remember the FSGS, what happens? Initially, there is a part or a fraction of the glomeruli which are involved, then the other glomeruli will take up the action, that is compensatory hypertrophy of the glomeruli will happen with increased capillary pressure and increased glomerular hypertension. And because of that, what happens is there is this compensation which is happening, thereby the progression of the immune injury is just getting taking place. It can happen from years, from months to years, right? So this is about the FSGS, light microscopy and electron microscopy. You see the effacement of food process. This is basically FSGS is a epithelial cell damage. Okay, the MPGN, what you see is a large hypercellular glomeruli. Then there will be, in the electron microscopy, you see the spikes. Okay, and then there is duplication of the basement membrane, which gives rise to a tram track appearance, right? So in the MPGN2, we find, in the light microscopy, we find the focal crescents. Crescents, I told you, are the result of proliferation of parietal epithelial cells. Okay, there can be proliferation of endothelial cells and visceral epithelial cells, but crescents are mainly by proliferation of parietal epithelial cells, and this is seen in MPGN2. And in addition to that, in electron microscopy, we see the ribbon-like dense material which is getting deposited, which is very classical of the dense deposit disease. You can see that the immunoglobulins in form of C3 are having granular deposits in MPGN, which are not seen on the dense material which is deposited, but on the basement membrane. Remember this, okay? In the immunofluorescence, we have subepithelial deposits in membranous nephropathy. There are no deposits in minimal change. In FSGS, we see C3 and IgM deposits, and in MPGN, we see the subendothelial deposits. Okay. Remember the morphology in divided in all the three ways. Now coming to the clinical features, all these disorders are giving rise to the primary glomerulopathies, which are giving rise to the nephrotic syndrome eventually, but initially they may have the nephritic features, including the hematuria and oliguria, right? In the membranous nephropathy, usually where it is insidious in onset, it is having nephrotic syndrome kind of picture with mild to moderate proteinuria. In minimal change disease, it can have moderate to massive proteinuria. Usually there is no hypertension or no hematuria involved. Usually it isn't seen in children and the prognosis is excellent and the response to the corticosteroids remains very, very good. So in membranous nephropathy, the prognosis is usually variable because the prognosis is usually being varied because of the progression either from the mild to moderate proteinuria or moderate to massive proteinuria. It may take months to years for it to go into end-stage renal disease. Now coming to focal segmental glomerulosclerosis, usually there is moderate proteinuria, hypertension, hematuria. You must also remember that the FSGS has something called as renal ablation type, which is usually a systemic manifestation of FSGS as a result of a unilateral renal agenesis or as a result of renal nephropathy. Reflex nephropathy. Okay. So because of reflex nephropathy or unilateral agenesis, there can be the renal ablation type of FSGS that is happening. Secondary form of FSGS that is happening after the two conditions. Okay, the end-stage renal disease is usually seen. It can progress with GFR less than 5%. It may take time until 10 years for it to form a end-stage renal disease. The membranous proliferative glomerulonephropathy 1, it has hematuria and mild proteinuria. 50% of the patients may eventually develop chronic renal failure. And here in MPGN, you can see that there are focal crescents. Crescents are usually the manifestation of the proliferation of parietal epithelial cells that we see in rapidly progressive glomerulonephritis. Also, here also we are seeing the crescents. Usually the crescents are related to poor prognosis. So this is a flow chart. If you remember this, you can write any kind of nephrotic syndrome, primary glomerulopathy. Right. So at a glance, we'll see what are the nephritic features and what we have dealt now, that is nephrotic features. Usually the post-infectious glomerulonephritis, the clinical presentation is nephritic syndrome manifested by hematuria, oliguria, and then I told you that it can be red cell class and azotemia. The pathogenesis is usually immune complex mediated. You know, the post-acute glomerulonephritis can be post-infectious related to streptococcus or non-streptococcus. Non-streptococcus can be having an IgA deposition. Here you can see that in the streptococcal, you can see the IgG and C3 deposition in the GBM and the mesangium. So what is happening? There is diffuse endocapillary proliferation and leukocytic infiltration because of activation of the leukocytes increasing factors and thereby recruitment of more number of leukocytes. So what you see by electron microscopy is usually the subepithelial humps is the characteristic of acute glomerulonephritis, and then there are subendothelial deposits which are seen in the early stage of the disease. And then we have not about the Goodpasture syndrome, a part of the rapidly progressive glomerulonephritis that can be renal limited or can be associated with Goodpasture syndrome, Goodpasture disease. Here we see that there is an antigen which is already in the glomerular basement membrane. You know, the glomerular basement membrane is made of this collagen, and there is an important thing called as a non-collagen 1 domain at the C-terminal. And then this NC1 domain will have an antibody coming and attaching to it. So why there is an immune complex formation. And because of this, there is an extracapillary proliferation with crescents and necrosis will be seen under the light microscopy, and the IgG and C3, and only the fluorescence micro linear IgG is a characteristic of the anti-GBM disease. Chronic glomerulonephritis, chronic renal failure, high-lens glomeruli, what we see, the deposits are usually granular. Membranous nephropathy, I told you the antigen PLA2R, that is phospholipase A2R, IgG, subepithelial deposits. Minimal changes is loss of glomerular polyanion, lipid in the tubules, loss of food process, and no deposits. FSGS, I told you the ablation nephropathy as a result of unilateral agenesis or as a result of reflex nephropathy. There can be porocyte epithelial damage is the main thing. IgM and C3 will be seen, and loss of food process and epithelial denudation is the main feature. So in MPGN1, usually it is by the activation of the classical and complement pathway. Here we are seeing there is IgG or C3, then subendothelial deposits, dense deposits here. So in IgA nephropathy, now I'll be talking in detail about the IgA nephropathy. There can be recurrent hematuria, proteinuria, and there is immune complex or whatever the pathogenesis is unclear. Here we have the focal mesangial proliferative glomerulonephritis, and then there is a mesangial widening which is happening that can be seen under the light microscopy. What is getting deposited? Obviously, IgA denotes the term immunoglobulin A that is getting deposited in the mesangium. So it can be seen individually as an Ig, or it can occur as in complexes with chains of immunoglobulin G. Then there is also activation of C3 which can be deposited in the mesangium. So thereby we can see the mesangial and paramesangial deposits. So now we'll go into the systemic disorders which are causing the nephrotic syndrome. That is the first one, IgA nephropathy, which is also called as a Burgess disease. So what we see just by the term IgA, that is immunoglobulin A, is getting deposited in the mesangial regions, and the most important clinical feature is the presence of recurrent hematuria. Usually, I'm also discussing these under those headings. Age, all the age groups can be affected, but usually it is seen in children, young adults. Okay. The most common type of glomerulonephritis worldwide is IgA nephropathy. So what symptoms you see is mild proteinuria is usually present, and the nephrotic syndrome may occasionally develop. Okay. There is a primary IgA nephropathy which can occur completely renal limited, or it can be as a result of primary means it can be idiopathic, I mean without any it just comes like that. Then secondary, it is occurring as a result of a liver or an intestinal disease. Okay, this is seen in some patients with celiac or some gluten kind of enteropathy or a liver disease. Okay. Then there is whenever we are seeing in a biopsy of the renal parenchyma IgA, then we should think of two diseases. One is Henoch-Spondyl purpura and the other one is IgA nephropathy. So whenever I am seeing the IgA nephropathy, how should I differentiate between the two when I am seeing a patient? So when I look at the renal parenchyma, I will see IgA nephropathy both resemble each other by the mesangial deposits of the immunoglobulin A. But in the clinical feature, you get to know that in Henoch-Spondyl purpura, you find the vasculitis as more advanced lesion, which can be seen with a history of antecedent history of either a throat infection or gastrointestinal symptom. So thereby you can take a history, then you can see that if there is a vasculitis involving the disease or not. Usually in HSP, there is no vasculitis that is involved in the renal parenchyma, but the vasculitis can be seen in other vessels of the gastrointestinal or the other viscera, as with skin. So, coming to the pathogenesis. See, IgA is something like a good student. You just sit with your book, in a monomeric form, in a room, you're trying to read or recollect or do whatever. So in IgA, usually is present in a monomeric form in the plasma. But what happens is that if you come to the class, you kind of have some friends, right? So you have good friends and bad friends. You don't know who are good and who are bad, but then, you know, after going along, getting along, then you try to mingle with people or mingle with other students or whatever. So IgA now becomes a polymeric form with a group of students or such. Usually, the liver, that is a guru or a teacher, acts as a person who is trying to remove the bad qualities and then trying to inculcate the good in the IgA. So something like that. So usually immunoglobulin A is present in the monomeric form in the plasma. It gets into the polymeric form, and then this polymeric form, increased synthesis of the IgA polymers will constitute degradation of all these IgA polymers in the liver. If this IgA polymers are not degraded in the liver, then what happens? They will get accumulated. It is like accumulation of something which is bad. Okay, so there is no control on that. So I just illustrated this diagram so that you'll remember this. Usually present in a monomeric form, IgA in a polymeric form, in the liver, which acts as a teacher, degrading all the bad qualities in you, degrades the IgA polymers into monomers. Okay. So whenever you're not aware of the bad circumstances around you, what happens? You get accumulated, you know, unknowingly or knowingly. So what happens? There is this deposition of polymeric IgA molecules with aberrant glycosylation. So what happens here is that there is an abnormal linkage of this sugar chain called as O-link glycans to the hinge region of the IgA molecule prior to their secretion by the B cells. You remember, the immunoglobulins are usually secreted by the plasma cells, right? Activated B cells. So prior to their secretion, what is happening? There is some bad thing which is coming and attaching to the IgA. So where it is attaching? To the O-link glycan, to the hinge region of the IgA. So increased polymeric form, abnormal linkage of the galactose containing sugar chain, all this will cause prior to the secretion of the B cells. So this is causing it, the deposition of something which is not required, right? So either this IgA, which is excessive in formation, is deposited by itself, that is, it's just individually getting deposited, or it may form immune complex in the circulation with IgG autoantibodies. So IgA may fight individually, or it may call somebody else to fight with it. You know, the couple fighting together. It's like that. So IgG will get complexed with IgA, and then both of them come together and they're fighting over something. So because of that, what happens? There is extracellular matrix formation, and numerous cytokines and growth factors are getting released. So what will these cytokines do? They will recruit more and more inflammatory cells, and there will be complement activation of the alternate complement pathway. There is opsonization and removal of these immune complexes, which are formed as a result of IgA, IgG, which are getting deposited, and these antigen antibody reaction, which are having present damage in the glomerular injury. It will be recognized as a potential danger to the renal parenchyma, and then it will try to come and degrade the already formed immune complex. So because of that, what is happening? There is eventually damage to the renal parenchyma. Okay. So I told you, in addition to the primary IgA nephropathy, there is a secondary form of IgA nephropathy that is occurring because of the inflammation or infection happening associated with the gluten enteropathy. So usually you know that IgA, immunoglobulin A, is essential or crucial part in the respiratory lining and lining mucosa and the gastrointestinal mucosa. So whenever there is an abnormality, some infection which is trying to manipulate with the normally present IgA, then what happens is that there is a damage to the epithelium and the immunoglobulin composition may get changed, so thereby the gluten enteropathy. And also the other thing I told you, the secondary liver disease that forms the IgA nephropathy. So what is the clinical feature? They maintain the renal function for decades together. This progression is very, very slow to the renal, chronic renal failure. I have very close friend of mine who have this IgA nephropathy, diagnosed almost 15 years back. Still, they're having a good renal function. Eventually, not the best of the renal function, but at least it hasn't even progressed to the end stage renal disease. But you have to keep checking the normal renal function, because once the damage is done because of the IgA deposition in mesangium, there will be the capillary proliferation and the mesangial proliferation that will happen, and recruitment of leukocytes. All these things will have an additional damage that can be seen in old age as in the form of heavy proteinuria, hypertension, extent of glomerulosclerosis. And what you have to do to know the progression, just have a renal biopsy. And always keep a check on serum creatinine to know about the urea and serum creatinine, to know the levels of azotemia you're progressing. So here we see, if you remember the glomerular structure, the basement membrane, the capillaries here are being supported by the mesangial cells in the mesangial matrix. Here you see there is proliferation of this mesangial cells. Okay, this is mesangial hypertrophy and mesangial cells, what you're seeing. In the immunofluorescence, you see that there is this granular deposition, mostly highlighted in the regions of the mesangium. That will give you a clue that you are looking at a IgA nephropathy. Okay. Now, after finishing the IgA nephropathy, now I will be dealing about the hereditary nephritis. That is a group of heterogeneous familial renal diseases associated with mutations in the collagen genes. Collagen, somewhere you heard, right? That is, while I was teaching about the basement membrane, I told you that the central dense material is there. There is the electron dense material in the center, then electron lucent materials present in the inner and outer layer called as lamina rara internal, lamina rara external. Right? So what happens here is that it will manifest a glomerular injury because of something which is not properly in, say, forming the structure of the glomerulus. What is happening here? We have to deal about the hereditary type of nephritis in form of alpots. Then there is something called as thin basement membrane lesion. So what we'll see that alpots first. There is a collagen which is important in the eye, in the kidney, and in the cochlea of the ear, right? So so a person coming to you with 3 involvement, eye deformity, hearing loss, and also the renal lesions, think of alpots. So here we have hematuria with progression to chronic renal failure accompanied by nerve deafness in various eye disorders include the lens dislocation, posterior cataracts, and corneal dystrophy. Usually this is an X-linked trait. X-linked trait, obviously, what females have XX, right? And males are XY. So if it is X-linked trait, what happens? Usually the disease is manifested almost all in the males, right? In the females who are heterozygotes, they will have only a hematuria, right? So what is the pathogenesis? The pathogenesis is obviously related to the collagen 4 molecule, which is essentially the basement membrane polymers, alpha 1 to alpha 6 chains. So the main chains which are involved in alpha 3, alpha 4, and alpha 5 mutations. Okay, there is defective assembly of the collagen network. So what do you see under the microscope? We see a typical thinning of the basement membrane, splitting of the basement membrane, having a basket wheel appearance. So very classical, the basket wheel appearance. Okay. So here we see the basement membrane. You see that there is this irregularity in the damage that has happened to this basement membrane as a result of the pathology that is happening in the alports or abnormal, irregular collagen molecules which are involved. So because of that, there is irregularity of this basement membrane, thereby the filtration won't happen properly. So coming to the other one, that is a basement membrane lesion. The basement membrane lesion is familial asymptomatic hematuria. Usually the basement membrane is of 300 to 400 nanometers thick. But here in the basement membrane lesion, what happens? The formation of basement membrane itself is thin. That is 150 to 225 nanometers. The prognosis is excellent. Usually the autosomal inheritance in most patients are heterozygous with a defective gene. Okay. So we have seen the systemic diseases. In the systemic diseases, we've seen the IgA nephropathy. Then I just shifted the focus to the hereditary disease, that is the alports and the thin basement membrane disease. Now we come to the chronic glomerulonephritis, CGN, which is a cluster of diseases. It doesn't entitle you to a definition of a particular disease pathology, but it is a cluster of diseases which come together to form the chronic glomerulonephropathy. That is as a result of either a crescentic glomerulonephritis, that is a rapidly progressing glomerulonephritis, which is present just with some few hours to days, but if it gets resolved, it may transform itself into chronic glomerulonephropathy. Then it may be very, very rarely seen now that, the post-infectious, nobody just leave the sore throat what they got. They are treating it very well so that the immune complex deposition to the renal parenchyma at that level is not happening. So the post-infectious, post-streptococcal glomerulonephritis ending into a chronic glomerulonephropathy is rare but can happen. Okay. Then membranous nephropathy, MPGN, IgA nephropathy, and FSGS all eventually may progress into chronic glomerulonephropathy. So, what is the morphology? Contracted and highly diffuse granular cortical surfaces, thinned cortex, obliteration of the glomeruli usually because of the insulation of the proteins. Okay, whenever there is hyalinosis and the insulation of the proteins or exudation of the proteins, they get accumulated on the renal parenchyma, thereby obliterating the glomeruli. And then these depositions also obliterate the glomerular capillaries. Okay. Then arterial and arteriosclerosis as a result of extracellular matrix deposition. So these are the four important features what we see as a result of a cluster of diseases going into chronic glomerulonephropathy. So this is a Mason trichome strain where you see here, this is almost lining all the glomeruli, the fibrin strands are taking over the glomeruli and there are loss of potential active normal glomeruli here in this picture. Okay. So now coming to something called as lupus nephritis. Lupus nephritis, as you know, is a disease which is seen maybe after 5 to 6 years of the diagnosis of systemic lupus erythematosus. Systemic lupus erythematosus is usually an autoimmune disease where there is loss of self-tolerance with activation of the self-reactive T cells and B cells. Okay. So what is happening, the butterfly rash, photosensitivity, the arthralgia, arthritis, all these things will happen, right, in lupus nephritis, if you remember. So there is a whole full class, house full of lesions that are occurring in the systemic lupus erythematosus, which if it involves the renal parenchyma. The WHO has classified these SLE lesions in the renal parenchyma as follows. The class 1, where there is minimal mesangial glomerulonephritis, usually with mesangial deposits only on the electron microscopy, resulting in the minimal change disease. Class 2, mesangial proliferative lupus nephritis. Okay. Mesangial-proliferative, there is proliferation of the mesangial cells in the capillaries. Typically responds good with corticosteroids. Corticosteroids play an important role, and corticosteroids response to the treatment will give you that there is an immune-mediated pathology involved in the production of the lupus nephritis. Class 3 focal proliferative nephritis. Okay, there is high focal fraction involved, diffuse, almost all the glomeruli involved. Class 5 membranous nephritis characterized by extreme edema, protein loss. Class 6 is advanced glomerulosclerosis, wherein the renal function is getting deteriorated more and more. The GFR is being very less. There is sclerosis and loss of normal functioning glomeruli, thereby the filtration is less, and then it may progress to end-stage renal disease. Okay. Now coming to henoch-scondyline purpura. Henoch-scondyline purpura is consisting of purpuric skin lesions, abdominal pain, intestinal bleeding, arthralgia, renal abnormalities, usually seen in 3 to 8 years old. I've told you this is a result of IgA nephropathy. Okay. In addition to IgA nephropathy, there is an additional what? Vasculitis. So the typical symptoms involved the extensor surfaces usually having the raised reddish purple spots or bruised areas like this. The joint inflammation and pain, abdominal pain, nausea, vomiting, bloody diarrhea, foot and ankle swelling as a result of the abnormal renal function. So somehow I have many people who I know having this kind of HSP. One of my friend's son was very well till 6-year-old, had an episode of an infection, and after that there was hematuria, and when they have investigated into that, he had henoch-scondyline purpura. He's doing fine with the corticosteroid treatment. So the prognosis is usually excellent. You know, hematuria, nephritic syndrome, nephrotic syndrome can be there with massive proteinuria. You have to be observing the patient unless and until the immune mechanism is it should stop, otherwise the damage is eventually progressing into nephrotic syndrome with massive proteinuria. Vasculitis not in kidney, I told you, vasculitis present in other areas in skin and gastrointestinal tract. So usually HSP preceded by an infection, then it will cause this, right? So there is another one called as fibrillary glomerulonephritis, that is membranoproliferative, mesangioproliferative patterns that we see in light microscopy. In immunofluorescence, we are seeing the IgG immunoglobulin G4 subclass, immunoglobulin G4 subclass and complement C3, immunoglobulin kappa and immunoglobulin lambda light chains are getting deposited. Fibrillary glomerulonephritis by the term is deposition of immunoglobulin light chains. Okay, so these fibrillary glomerulonephritis are different from the amyloid type of glomerulonephritis because they do not stain with the Congo red. They are not a part of amyloid, right? Remember this. So that there is deposition of the immunoglobulin kappa and lambda light chains. Fibrillary glomerulonephritis should be differentiated from amyloid nephritis. Amyloid nephritis, I told you, is what? Amyloid nephritis, while we are discussing in immunology, we spoke about the amyloid nephropathy, wherein there is misfolded proteins. Amyloid is nothing but there is accumulation of the unwanted misfolded proteins, okay, in the form of light chains or in the form of amyloid, serum amyloid proteins, right? It can be accumulated in relation with the glycoproteins. Then it may cause eventually the disease. Usually we see that the amyloid is extracellular homogeneous material which can be stained with Congo red. Okay, and it can be seen under the polarized microscope, if you remember. Just I am trying to recollect so that you remember this amyloid nephropathy, which is almost formulated to the fibrillary glomerulonephritis, and how it is different is the difference of the chains and then the Congo red stain. Then others. The glomerulonephritis can be associated with bacterial endocarditis. Sorry for the It's not bacterial endocarditis, it is bacterial endocarditis. It can be seen in the form of focal segmental necrotizing glomerular lesions or diffuse glomerular exudative proliferative glomerular nephropathy. Okay, so the lesion can be focal segmental or necrotizing. The lesion can be diffuse glomerular exudative, diffuse global exudative, or proliferative. I just wrote in a short form so that you have to remember what is FSN, right? So the other one I told you is about the essential cryoglobulinemia, which is causing membranoproliferative glomerulonephritis. Cryoglobulinemia is an immune-mediated disease wherein there is deposition of IgM and IgG complexes. Okay, there is these complexes which are getting deposited, and because of that, there will be membranoproliferative glomerulonephritis. Kidney is involved along with the skin lesions. So coming to the last one, that is diabetic nephropathy. See, today's class I told you about the primary glomerulopathies, that is minimal change, membranous, MPGN1, MPGN2, and FSTs. Okay, finish. According to that, again I told you about the hereditary, that is 2 lesions involved in hereditary, Alport, and thin basement membrane. That's done. Now, in the systemic diseases which are causing the secondary forms of glomerulopathies are the diabetes, amyloidosis, cryoglobulinemia, lupus, all these things, the endocarditis, which is causing the fibrillary glomerulonephropathy, all these things are the secondary forms of the glomerular lesions. Okay, primary lesions, glomerular lesions, and hereditary. Coming to the diabetic nephropathy, why diabetes causing the disease? Usually in diabetes mellitus, after 15 years, after the initial diabetes manifestation, diabetes mellitus, there will be progression to the advanced disease that is either a microvascular disease or a macrovascular disease with the involvement of renal parenchyma, eye, heart, vessels, everything. So coming to our topic today, that is a renal parenchyma involvement in the diabetic people will be seen only in the basis of uncontrolled sugar, only the accentuation of almost years together, maybe 15 to 20 years. So what is happening is there is this pathogenesis of diabetic nephropathy is accumulation of advanced glycosylation end products that are formed as a result of the glucose, which is getting bound to the amino acids that are present on the tissue. The tissue proteins, okay, they get binded and then they form the advanced glycosylation end products. These get deposited on the basement membrane and other tissues. So because of that, there are some hemodynamic changes and the growth factors are getting released and there will be some hormonal disturbances. What is happening pertaining to the advanced glycosylation end products? Their position in the basement membrane of the renal parenchyma are increased glomerular hyperfiltration, altered glomerular composition, renal hypertrophy, glomerular hypertension as a result of a macrovascular disease and a microvascular disease, both. Okay, so what is happening? There is albuminuria, deposition of extracellular matrix leading to glomerular sclerosis and interstitial fibrosis. If you remember AGs, that is advanced glycosylation products as a result of lupus bounding to the amino acids pertaining to the tissue proteins, you get this. So what is happening here? We can see the glomerulus here. There is an afferent arteriole, the efferent arteriole, the bounding space, the urine. The protein leak is happening with the blood vessels in the diabetic nephropathy. So what are the pathological lesions in diabetic nephropathy? In diabetic nephropathy, we can classify the lesions pertaining to the renal parenchyma as 3. One is pertaining to the glomerulus, pertaining to the vessels, pertaining to pyelonephritis. Okay, 3 lesions. First one, glomerular lesions. In glomerulus, what is happening? Basement membrane thickening is happening because of the deposition of the advanced glycosylation end products. The other one is diffuse mesangial sclerosis as a result of the mesangial proliferation that is happening. Nodular glomerular sclerosis or Schimel-Steele Wilson disease wherein there is collagen deposition happening in the form of nodules. Okay, so because of that, there is mesangial loss, fraying of the mesangium. Okay, there is proliferation of the capillaries. This is classical of the Kimmel-Steele-Wilson disease. Nowhere you will see, but in diabetic nephropathy. Then there is something else called as fibrin gaps and capsular drops. They are as a result of non-collagenous. See, nodular glomerulosclerosis is a result of collagenous. But fibrin gaps and capsular drops are as a result of non-collagenous substances that are getting accumulated either beneath the Bowman space, that is capsular drops, or either beneath the capillaries that are called as fibrin gaps. Caps, capillaries, capsular drops is in the space, okay, that is in the Bowman space. So this is pertaining to the glomerular lesions. Coming to the renal atherosclerosis, that is a macrovascular disease involving the diabetic nephropathy. As a result, usually the diabetes is associated with hypertension. There is abnormal vascular lesions that are also seen in the diabetic nephropathy, the renal lesions, in the form of arteriosclerosis or atherosclerosis, wherein the vessels are lined by the lipid, abnormal lipid. So there is constriction, there is no proper flow, increased intraglomerular capillary pressure. Okay, remember this is happening as a result of macrovascular disease. Pyelonephritis is usually necrotizing type of necrotizing papillary type of pyelonephritis as a result of infection that can happen in diabetic nephropathy. Is the classical lesion that can happen only in diabetic nephropathy. So three things: glomerular lesions in diabetic nephropathy, atherosclerosis or the vascular disease, then the pyelonephritis. Remember, three major lesions that are occurring in the diabetic nephropathy. So thank you. That will end today's class. Tomorrow, so we have dealt about the primary, secondary and hereditary today. Tomorrow I'll be dealing about the tubulointerstitial diseases. Okay, thank you. I hope you are trying to recap with me and connect to the whole renal pathology. Right? Thank you.